The pathophysiology of pulmonary fibrosis. Pulmonary fibrosis is a chronic progressive lung disease characterized by excessive deposition of fibrous tissue in the lung parenchyma, leading to impaired gas exchange and respiratory failure. The pathogenesis of PF, which is pulmonary fibrosis, involves a complex interplay between genetic predisposition, environmental triggers, and dysregulated cellular and molecular processes. The primary event in PF is the aberrant response to alveolar epithelial injury, resulting in excessive fibroblast proliferation, myofibroblast differentiation, and deposition of extracellular matrix components such as collagen and fibronectin. This leads to stiffening of lung tissue, reduced lung compliance, and progressive decline in pulmonary function. There are different types of pulmonary fibrosis. It's classified into two different types based on the etiology. First, starting with idiopathic pulmonary fibrosis, that's the pathophysiology that I drew on this slide. It is the most common and severe form, characterized by progressive scarring of lung tissue without a known cause. Idiopathic pulmonary fibrosis typically presents with usual interstitial pneumonia histology, marked by fibroblastic foci, honeycombing, and interstitial inflammation. The second one is secondary pulmonary fibrosis. This develops as a consequence of known causes such as autoimmune disease, like rheumatoid arthritis, systemic sclerosis, as well as environmental and occupational exposures, drug-induced fibrosis from like chemotherapy, amiodarone, nitrofurantoin as well, and radiation-induced fibrosis, seen in patients who undergo radiation therapy for lung or breast cancer. The third one is genetic pulmonary fibrosis. This is caused by inherited mutations in genes such as TERT, TERC, and surfactant protein genes, leading to premature lung fibrosis. At the cellular level, pulmonary fibrosis begins with repetitive injury to the alveolar epithelium, particularly to type 2 alveolar epithelial cells, AECs abbreviated, which play a crucial role in surfactant production and lung repair. Dysregulated repair mechanisms lead to epithelial cell apoptosis and the release of pro-fibrotic mediators such as transforming growth factor beta, connective tissue growth factor, and platelet-derived growth factor. These factors activate fibroblasts, causing their proliferation and differentiation into myofibroblasts, which are the primary producers of ECM proteins like collagen and fibronectin. Persistent myofibroblast activation results in excessive ECM deposition, leading to alveolar thickening and distortion of the lung architecture. Additionally, abnormal crosstalk between fibroblasts, macrophages, and endothelial cells exacerbates inflammation and fibrosis. The dysregulation of matrix metalloproteinases, also abbreviated as MMPs, and tissue inhibitors of metalloproteinases further contributes to ECM remodeling and fibrosis progression. Vascular remodeling, endothelial dysfunction, and microvascular loss impair oxygenation, leading to worsening respiratory insufficiency. Ultimately, as fibrosis advances, lung compliance decreases, gas exchange is severely impaired, and patients develop progressive dyspnea and respiratory failure without effective intervention. Pulmonary fibrosis leads to end-stage lung disease with a median survival of 3 to 5 years in cases of IPF, despite ongoing research, treatments, remain limited, and antifibrotic drugs like nintedanib and pirfenidone offering only modest benefits in slowing disease progression.